Welcome back to the deep dive. Today we are wading into some truly fascinating waters. We're looking at a topic that sits right at the intersection of embryology, how we're built in the womb, and some pretty high-stakes surgery. We're talking about congenital neck swellings.
It sounds a bit niche, doesn't it? But when you actually dig into the material, as we have, you realize it's not just about like random lumps and bumps. It's a masterclass in human anatomy. It's basically a detective story where all the clues are written right there on the patient's neck.
Exactly. And the source material we're working with today, it's really designed to be a kind of cheat sheet for diagnosing these things. It frames these swellings, not just as pathologies, but as very specific leftovers.
For mistakes?
All right, mistakes from the body's whole construction process.
That is the perfect way to frame it. I mean, these aren't random growths like a tumor that appears out of nowhere. These are echoes of our development.
So our mission today is to help you, our listener, navigate this really complex map of the neck. We want to get you to a point where you can look at a lump, see where it is, see how it behaves, and pretty much know what it is before anyone even, picks up a scalpel.
And why this matters is, well, the source highlights that even though these are congenital, meaning you're born with the potential for them, they often don't actually show up until childhood or even young adulthood.
Oh, interesting.
So clinically, this is a super common puzzle. You'll have a child, a young adult, coming in with a sudden bump. Parents are worried, the patient's worried. And the difference between a benign cyst and a surgical disaster is just understanding the anatomy.
Right. And speaking of anatomy, the source material gives us this incredible cheat code right off the bat.
Yeah.
It basically says, anatomy is destiny.
It really is. It really is. In diagnostic medicine, we often look for these complex biomarkers or genetic tests, but here, it's like real estate. Location, location, location.
And the big divide, the Great Wall of China for these neck lumps, is simply midline versus lateral.
It sounds almost too simple to be true, doesn't it? But that is the golden rule our sources just keep hammering home. If you can just draw an imaginary line down the center of the neck from the chin down to the top of the sternum and just figure out if the swelling is on that line or off to the side.
You've already cut your list of suspects in half.
Exactly. It is the most powerful filter we have, by far.
Okay, so here's the overview of our journey today. We're going to start with what we're calling the midline heavyweights, specifically the Thyroglossal duct cyst, which sounds like a mouthful, but it's super common. Then we'll look at the imposters, things that look like cysts but are definitely not, like ectopic thyroids. Then we travel over to the lateral side, the side of the neck, to look at branchial cleft anomalies and the mysterious cystic hygroma.
And you have to stick around for the end because there is a major plot twist when we talk about how this all changes if the patient happens to be an adult.
Oh, definitely. That part actually gave me chills. Okay, so let's unpack this core concept first. We mentioned these are leftovers. What does that actually mean in this context?
Well, think about how a human face and neck form in the womb. It's a pretty chaotic process of tissues folding and tubes descending and these clefts closing up. It's like a really complex origami project.
Right.
And usually all the seams vanish and the scaffolding gets taken away. But with these congenital swellings, something got left behind. A duct didn't close. A piece of tissue got trapped.
So these lumps are basically historical artifacts of our own creation.
Precisely. They are archaeological sites on the body. And that's why the whole midline versus lateral rule works so well. Different embryological events happen in the center compared to the sides. The midline is where the thyroid descends and the tongue forms. The lateral neck, well, that's where the branchial arches, our ancient sort of gill-like structures, fuse together. They are totally different neighborhoods.
Okay, let's dive into the center then, the midline. And the undisputed champion, the heavyweight of midline neck swellings, has got to be the thyroglossal duct cyst.
This is by far the most common congenital neck swelling you'll ever encounter. If you see a lump in the middle of a child's neck, statistically, this is your safest bet.
So what's the origin story here? Because thyroglossal sounds like a mashup of thyroid and glossal, which means tongue, right?
You absolutely nailed it. And that name, it tells you the entire history of the thing. See, the thyroid gland doesn't start in the neck where we, find it in adults. It actually starts developing at the base of the tongue at a very specific spot called the foramen cecum.
Wait, hold on. Let's pause there. Our thyroid, the gland that controls our metabolism, it starts in our mouth.
Effectively, yes. It starts as this little budding of cells at the very back of the tongue. And as the embryo develops, that thyroid gland has to migrate. It takes a road trip. It travels from the base of the tongue, dives down through the floor of the mouth, passes the hyoid bone, and then settles into its final resting place, lower down in the neck.
And it travels along a path, I'm guessing?
A literal tube. It's called the thyroglossal duct. Now, normally, once the thyroid arrives at its destination, that road, the duct, it's supposed to just disappear. It essentially disintegrates because its job is done. But
in this case, the demolition crew didn't show up.
exactly. Sometimes parts of that road remain open, and fluid collects in those leftover spaces, mucus, secretions, and boom, you get a cyst, a thyroglossal duct cyst.
Okay, so knowing that backstory, how do we spot it? The source says it's usually midline, specifically below the hyoid bone. But there's a magic trick to diagnosing this, isn't there? This is the part I love because it's just so mechanical.
This is classic clinical medicine at its best. You don't need $1 million scanner for this one. If you have a patient with a lump in the middle of their neck and you suspect this, you ask them to do two things. First, swallow.
And the lump moves.
It moves up. But, to be honest, everything in the neck moves when you swallow the larynx, the thyroid itself. So that's not specific enough. The second command is the clincher. You ask them to stick their tongue out.
And what happens?
The lump shoots upward.
That is wild. Why would sticking your tongue out move a lump in your neck?
It goes right back to that road trip we were talking about. The cyst is formed from the remnant of the duct, and that duct is still physically tethered to its point of origin, the base of the tongue, that foramen cecum.
So it's like a puppet on a string.
It is exactly a puppet on a string. So when you push your tongue out, you are literally pulling on that tether, and it drags the cyst upward with it.
That is such a satisfying explanation. It's physically anchored to the tongue.
It is. And that movement is diagnostic. If it moves with tongue protrusion, it is almost certainly a thyroglossal duct cyst. It confirms that embryological connection.
Okay, so we know what it is.
Yeah.
Now we have to get rid of it. And this is where the surgery gets tricky. The source mentions something called the Sistrunk Operation.
It sounds pretty intense. Why can't we just, cut the cyst out, just scoop it out and be done with it?
And that is the trap. That's the trap that inexperienced surgeons can fall into. If you just do a simple excision, just cut out the lump, you can see the recurrence rate is massive. It will almost certainly come back.
But why? If you took the bag of fluid out, why does it return?
Because you haven't removed the source. You haven't removed the tract. Remember, it's a duct. It goes through structures.
Yeah.
And crucially, it passes intimately close to and sometimes even through the hyoid bone.
The hyoid bone, that's that little floating bone in the neck, right? Correct. And in the embryo, the hyoid bone often forms around the duct. So the microscopic tract can literally run right through the center of the bone. If you just peel the cyst off the bone and leave the bone behind, you've left the seeds of the disease.
So the Sistrunk operation, it acknowledges that you can't just take this cyst. You have to go deeper.
Exactly. Dr. Sistrunk figured this out back in 1920. To cure it, you have to take the entire tract. And that means you remove the cyst, you remove the tract going up towards the tongue, and this is the key part. You actually cut out and remove the central part of the hyoid bone itself.
Whoa. You take a piece of the bone.
You have to. You core it out, and then you continue that dissection all the way up to the base of the tongue. You have to remove the entire highway.
Does removing part of that bone cause problems? I mean, don't we need our bones?
Surprisingly, not really. The hyoid is pretty unique because it doesn't articulate with other bones. It's just held in place by muscles. The cut ends either scar together or they're sutured, and the patient swallows just fine. The trade-off is absolutely worth it because the recurrence rate drops to almost zero.
So to cure the leftover, you have to remove the entire path it traveled.
Exactly. The anatomy guides the surgery. You can't cheat the anatomy.
Okay, so that's the thyroglossal duct cyst.
Yeah.
Midline, moves with the tongue, needs the Sistrunk operation, but it's not the only thing we find in the midline.
No, it's not. And this is where things can get dangerous if you aren't paying close attention. We have some imposters.
Let's talk about the dermoid cyst first. How is this one different from the thyroglossal one?
Well, embryologically, a dermoid cyst is completely different. It's basically trapped skin. We call it an inclusion cyst. During those folding processes in the womb, a little piece of ectoderm, which is skin tissue, got, trapped deeper in the body where it doesn't belong.
So it's literally a pocket of skin inside the neck.
Right. And because it's skin, it acts like skin. It sheds dead cells, it produces oils. Sometimes it can even have hair inside.
The source describes the texture as doughy. That's a very specific word.
It is, and it's really accurate. A thyroglossal cyst is filled with mucus, so it feels tense, kind of like a grape or a water balloon. A dermoid cyst is filled with that cheesy, keratinous material, so it feels softer, more moldable, like dough.
And it's usually found in the submental region, so right under the chin or midline. But here's the million-dollar question. Does it move when you stick your tongue out?
It does not, and that is your key differentiator. A dermoid cyst has no connection to the tongue. It's just a trapped pocket of skin. It has no tether. So you get that doughy texture, but you get no movement with tongue protrusion.
Simple enough. Doughy plus no movement equals dermoid. But now, let's talk about the scary one, the ectopic thyroid.
Ah, yes. This is the one that keeps surgeons up at night. This is the do not pass go, do not collect $200 scenario.
The source calls this a dangerous trap.
Okay, so go back to that thyroid road trip we discussed. We said the thyroid travels from the tongue down to the lower neck. But what if the car breaks down? What if it gets a flat tire and just stops halfway?
Then you have a thyroid sitting in the middle of the neck, but way too high up.
Exactly. That is an ectopic thyroid. It's thyroid tissue that failed to descend completely. It's often found right at the base of the tongue. We call that a lingual thyroid, or in the suprahyoid region, which is exactly where you'd find a cyst.
Okay, so visually, it looks like a lump. It's in the midline. Why is it a trap?
Because, and this is crucial, if a surgeon mistakes that lump for a cyst and just cuts it out, they might have just removed the patient's only functioning thyroid tissue.
Oh, wow. So the patient doesn't have a normal thyroid lower down.
Often, no. That lump is their thyroid. It just didn't make it to the right address. If you remove it thinking it's a disposable cyst, you have just rendered that child permanently hypothyroid. They will need hormone medication for the rest of their life because you threw their thyroid in the pathology bin.
That is a massive, massive error.
It is a catastrophic error, and that is why the source has a big, bold, do not touch rule, it says. Never, ever, ever excise a midline neck mass without first confirming that there is normal thyroid tissue where it's supposed to be.
So you have to check first, before you even think about scheduling surgery.
You must. You have to. You do an ultrasound or a thyroid scan. You have to prove there is a normal thyroid gland sitting lower in the neck before you touch that midline lump. If you can't find a normal thyroid, you put the scalpel down. You do not touch that mass.
That is such a crucial takeaway. I mean, it really emphasizes the do no harm principle. You have to know what you are cutting before you cut.
Absolutely. You cannot uncut a thyroid.
Okay, let's leave the midline. We're crossing the border. We're now moving to the side of the lateral region. What do we find here?
Welcome to the world of branchial cleft anomalies.
Branchial. That refers to gills, doesn't it?
It does. It comes from the Greek word for gills. In the early embryo, humans actually have these structures called the branchial apparatus arches and clefts. In fish, these become gills. In us, nature recycles them to build our jaw, our ears, our neck muscles, things like that.
But like the thyroid duct, these clefts are supposed to disappear or transform into something else.
Right. They're supposed to fuse together and smooth over completely, but when they don't...
You get a branchial cleft cyst, or I guess sometimes a sinus or a fistula.
Correct. A cyst is a closed sac. A sinus is a little tunnel that opens to the skin. And a fistula is a complete tunnel that connects the skin on the outside all the way to the throat on the inside.
The source calls this a very high-yield topic for exams and things. So, where specifically are we looking? The midline had the hyoid bone as a landmark. What's the landmark for the lateral neck?
The landmark here is the sternocleidomastoid muscle, the SCM. That's the big strap-like muscle that pops out when you turn your head to the side. It runs from just behind your ear down to your collarbone.
Okay, I'm visualizing it now.
Branchial cleft anomalies are almost always located right along the anterior border, the front edge of that muscle.
So if I see a smooth, painless swelling on the side of a kid's neck, right along that big muscle,
Bingo.
bingo, it is highly, highly suspicious for a branchial cyst. Specifically, the source notes that the second branchial cleft cyst is the most common type by a huge margin.
Why second? Are there others?
Oh yeah, there are 4 clefts in the embryo. First, second, third, and fourth. The first one is way up near the ear. The third and fourth are much lower down. But the second cleft is the one that persists most often. We're talking like 95% of the time. So statistically, if you see a lateral cyst, it's a second branchial cleft cyst.
Now let's talk treatment. With the midline cyst, we said simple excision is a bad idea. What about here? Can we just drain it, say it gets infected and looks all red and angry. No. And this is another huge exam trap, and more importantly, a clinical trap that the source points out. You might be tempted. It's a fluid-filled sac. It looks like an abscess. You might think, oh, I'll just do an incision and drainage, an I&D, let the fluid out, relieve the pressure, and it'll be fine.
Yeah, that sounds logical if it's infected.
It is absolutely the wrong move.
Why?
Because incision and drainage leads to infection and recurrence. And even worse, it can turn a clean, contained cyst into a chronic draining sinus. You essentially create a permanent hole that just leaks mucus onto the skin.
Yikes. So you turn a contained problem into a leaky, messy one.
Exactly. And once you've cut into it and caused all that scarring, the definitive surgery to actually cure it becomes so much harder. The nerves in that area, and there are very important ones, they get all stuck in the scar tissue. It's a mess.
So what's the correct approach then?
You treat the infection with antibiotics first. You let everything cool down. And then once it's calm, you take them to the operating room for a complete surgical excision. You have to remove the cyst wall entirely. Never just poke it.
Got it. So lateral neck plus the SCM muscle equals branchial cleft. And the treatment is complete excision, never just drainage.
Correct.
But wait, there is another lateral suspect, isn't there? The lymphatic mystery, the cystic hygroma.
Yes, also known as lymphangioma.
This one feels different. It's not a leftover cleft. It's not a duct. What is it?
This is a malformation of the lymphatic system itself. So the lymphatic system is kind of like the body's drainage plumbing. In this condition, the lymphatic sacs in the neck fail to connect properly to the main plumbing, so they just dilate and form these massive multi-lobed collections of fluid. Think of it like a big sponge made of fluid-filled bubbles.
And where did this one tend to hang out?
Well, while branchial cysts are usually in the anterior part of the neck, near the front of the SCM, cystic hygromas love the posterior triangle. That's the area behind the SCM muscle, back towards the shoulder.
Okay, so further back on the side of the neck.
Usually, yes. And they look different. They're very soft, cystic, and often quite large. They can be disfiguring. But there's a really cool physical exam test for this one, too.
The light test.
Transillumination. Because these cysts are filled with clear lymphatic fluid, it's like water, and they have very thin walls, if you shine a bright light against them in a dark room, the whole thing lights up.
It glows.
It glows. We call it brilliant transillumination. It's really quite striking to see.
That is a great image. So if it lights up like a lantern, think cystic hygroma.
Exactly. Branchial cysts usually have thicker walls, or the fluid inside might be different, like pus or cholesterol crystals, so they don't light up nearly as well. But a cystic hygroma will just shine.
Now, management here sounds messy. The source says surgery is difficult. Why is this one harder to remove than the others?
Remember I said it's like a sponge? It doesn't have a nice, neat capsule like the other cysts do. It tends to infiltrate. It grows in and around nerves, in and around blood vessels, between the muscle fibers.
Oh, I see. So it doesn't just push things out of the way. It wraps around them.
Exactly. It's not like plucking a grape off a vine. Finding a clear margin is a nightmare. If you try to cut it all out, you risk damaging vital structures, nerves that control the shoulder, major blood vessels. It's a very, very high-risk surgery.
So what do they do instead?
Sometimes they do have to operate, but often they'll turn to something called sclerotherapy.
Sclerotherapy, what's that?
It's where they inject a medicine directly into the cyst that causes it to scar down and shrink from the inside. They use agents like picibanil or bleomycin. It basically attacks the lining of the cyst chemically rather than physically trying to dissect it out.
That makes a lot of sense. Attack it from the inside because the outside is just too tangled up with everything else.
Right. It avoids that whole risky dissection.
Okay, so we've covered the kids. We've covered the congenital stuff. We've got our map. Midline moves with the tongue is a thyroglossal. Lateral by the SCM is branchial. Posterior and glows is a cystic hygroma. But now we have to talk about the plot twist.
The adult plot twist,
Yeah.
yes.
The source puts a huge emphasis on age. Everything we just discussed applies mostly to children and young adults. So what happens if, say, a 50-year-old walks in with a new lump in their neck that looks exactly like a benign cyst?
The entire game changes instantly. The rule book we just spent all this time learning, you have to add a massive warning label to the front. You almost have to throw it out.
Why? What's different?
Because in an adult, especially an older adult, a new lateral neck mass is malignancy until proven otherwise.
Cancer.
Cancer. Even if it looks like a cyst. Even if it feels like a cyst.
But how can cancer feel like a cyst? I always thought cancer was supposed to be hard and rocky.
Often it is. But specifically in the head and neck, squamous cell carcinoma, which is the common throat cancer, It loves to metastasize to the lymph nodes in the neck. As that cancer grows inside the lymph node, it outgrows its own blood supply. So the center of the tumor dies and liquefies. This is called cystic degeneration.
That is terrifying. So you're saying it's a rotting lymph node that's mimicking a benign fluid-filled cyst?
Exactly. And here's the tragedy. If a surgeon sees a 50-year-old with a lump, thinks, oh, that looks just like a branchial cleft cyst, and just cuts it out, they have made a grave, grave mistake.
Because they've spread the cancer.
They've disturbed the tumor, they haven't treated the primary source, which might be hiding in the tonsil or the base of the tongue, and they've completely compromised that patient's chance for a proper cure. A branchial cleft cyst appearing for the first time in a 50-year-old is almost unheard of. It is far, far more likely to be a cystic metastasis from a throat cancer.
So the golden rule for adults is?
Rule out cancer first. Do not assume it's congenital just because it looks like the pictures we've been describing. You need a fine needle aspiration, a CT scan, you probably need to scope the throat. The stakes are just totally different.
Wow. That is a sobering but absolutely necessary check on everything.
Yeah.
It really shows how context like age completely changes the interpretation of the anatomy.
Absolutely. The what is the same a lump, but the who changes the why completely.
Okay, we have covered a huge amount of ground. Let's do a rapid-fire recap to really lock this in for our listeners.
Yeah.
I'll throw out the clue. You give me the diagnosis. Ready?
I am ready. Let's do it.
Clue number 1. Midline lump in a child. Moves when I swallow and stick my tongue out.
That's your thyroglossal duct cyst. Classic.
Okay. Clue number 2. Lateral neck lump. It's sitting right on the anterior border of that big sternocleidomastoid muscle.
Branchial cleft cyst. Almost certainly the second cleft.
Clue number 3. A posterior neck swelling. It's soft, it's squishy, and it glows when I shine a flashlight through it.
Cystic hygroma, or lymphangioma.
Clue number 4. Midline. Doughy texture. Does not move with the tongue.
Dermoid cyst.
And finally, the big safety check. A midline mass high up in the neck. What do I never do?
You never cut it out without checking for a normal thyroid first. It could be an ectopic thyroid, and that could be all they have.
And the surgical technique? Simple excision is okay.
Never. Simple excision fails. You need the Sistrunk Operation for thyroglossal cysts. You've got to take the hyoid, and complete excision for branchial cysts.
Amazing. It really is a logic puzzle when you break it down.
It is. And if you follow the logic, the location, and the behavior, you get the answer.
So, as we wrap up this deep dive, what does this all really mean? We started by saying anatomy is destiny.
You know, I think the biggest takeaway here is that our bodies are walking history books. A lump in the neck isn't just some random event. It's a map of your own embryological journey. It tells the story of how your thyroid migrated, how your gill slits closed or didn't, how your skin folded over itself.
I love that perspective. It really turns a scary symptom into a story.
It does. And for a clinician, or just for anyone interested in how we work, learning to read that map is absolutely crucial, because misreading the map, like confusing a vital organ for a disposable cyst, can have lifelong consequences. It's about having respect for the incredible complexity of how we're built.
That is a really powerful thought to leave everyone on. Next time you look in the mirror or see someone with a bump on their neck, remember, there is a whole history written right there if you just know how to read it.
Just maybe don't go poking people's necks at dinner parties.
Good advice, as always. Thanks for listening to this deep dive. We'll see you next time.